Good morning. Welcome back to OpenMed School. Today we are going to discuss about winging of scapula. The objectives of today's presentation is to describe the causes of winging of scapula and the types of winging of scapula. As we know, scapular winging is due to a dysfunction of the stabilizing muscles of the scapula, which result in abnormal motion of the scapula. The diagnosis is made clinically and appropriate investigations like imaging, electromyogram, and nerve conduction studies are also used in appropriate situations. Let us see what are the muscles which stabilize the scapula. And here you can see the scapula, you are seeing the trapezius muscle that is originating from the external occipital protuberance, the nuchal line, and from C7 to T12 vertebrae. So this is the origin and is inserted to the scapula like this. And behind the trapezius, you can see this is the rhomboids muscle. The rhomboids major and rhomboids minor, which is attached to the medial border of the scapula. There is another important muscle that stabilizes the scapula, that is the serratus anterior. It originates from the first 8 or 9 ribs and it is attached to the inner aspect of the medial border of the scapula. And so when this muscle contracts, the shoulder is pushed forwards and is sometimes called the boxer's muscle. So let us see the movements of the scapula. You can see the rhomboids pulls the scapula medially. The trapezius also pulls it towards the medial side. So if the rhomboids or the trapezius are weak, the scapula will be moving laterally. That is called the lateral winging. In contrast to weakness of the serratus anterior muscle is making the scapula move forwards, slide over the chest. So when this muscle is weak, what will happen? The scapula will move medially. So we can see that there is opposing action. The rhomboids and the trapezius tries to hold the scapula towards the midline. So if there is a weakness, the scapula moves laterally. Whereas serratus anterior weakness, the scapula will move medially and upwards. So this constitutes the two types of winging, that is a lateral winging and the medial winging. Hope this point is clear to you. And this is the rhomboids which we have discussed. We can see that the rhomboids are attached to the medial border. When there is a weakness, the lower pole especially goes laterally. It originates from the ligamentum nuchae and spines of 7th cervical vertebrae and the first thoracic vertebrae, C7 and T1. It is inserted to the medial border of the scapula and the nerve supply is by C4, C5, the dorsal scapular nerve. So this is what we are talking. This is the midline. When the scapula goes medially it is called medial winging. So this is the normal side. Here they can see the scapula has moved medially. The distance between the midline and the medial border scapula has reduced. So it's medial winging. Here you can see that the scapula has moved from the midline outwards. So this is lateral winging. As explained earlier, lateral winging is due to trapezius weakness or rhomboids weakness, and medial winging is due to serratus anterior weakness. The true winging of scapula is due to serratus anterior dysfunction. This is supplied by the long thoracic nerve of Bell, C5, C6, C7. The testing is by asking the patient stand 2 feet from the wall and then push against the wall with the flat palms at the base level. That is, you are asking the patient to push against the wall. And this is the origin of the nerve. From the C5, 6 and C7 roots it is originating. It has got a long course and is liable to be involved in injuries, especially repetitive movements like throwing ball or a sharp blow on the shoulder. Accidents, this can be injured. So winging of the scapula can be due to, most important cause, serratus anterior. It can be due to the trapezius involvement or due to the rhomboids. These are rare. The most common cause of serratus anterior injury is traumatic or sports related. It can occur following influenza, can be iatrogenic following a vaccination, especially when bilateral. Think about congenital diseases like muscular dystrophy. The classical one is facioscapulohumeral muscular dystrophy. Very important condition which can occur spontaneously is the neuralgic hematrophy or Parsonage-Turner syndrome. It is called a neuralgic hematrophy because there is severe pain is there. So patient develops severe pain over the shoulder, especially C5-6 roots, and the muscles which are supplied by C5-6, or sometimes it may extend further. The muscles get wasted, and in this condition there can be, as there is involvement of C5 and 6, there is involvement of the long thoracic nerve and serratus weakness can occur. So lateral winging is classical of trapezius. Here what is happening, from the midline, the shoulder blade moves laterally, and usually the medial border, especially the lower part, will be little towards the middle side because of the attachment of the trapezius. When the upper fibers are affected, the shoulder blade may move laterally, especially the upper part. This is an example of bilateral winging. You can see that the shoulder blade is prominent. The lower part is coming little medially. And this is commonly due to congenital conditions like facioscapulohumeral muscular dystrophy. This is to explain the serratus anterior the rhomboids weakness. When the rhomboids are affected, naturally the action of the rhomboids is to pull the scapula medially. So weakness of rhomboids will lead on to lateral winging. Especially the lower pole of the scapula will be shifted outwards. So this is the lateral winging. The movement is subtle, and in addition to the winging, you can see when you keep the hands over your shoulder and resistance is applied for the posterior movement. Keep the hands over the hip and then apply resistance to posterior movement we can easily identify the rhomboid's involvement. We have already discussed the brachial plexus, plexitis, or the Parsonage-Turner syndrome is a extremely painful condition. It starts with pain, and once the pain disappears, patient notes that there is weakness of the periscapular muscles. So, we have already discussed the medial winging and lateral winging, and the medial winging is by the long thoracic nerve C567, and lateral winging is due to spinal accessory involvement or the dorsoscapular nerve which supply the rhomboids. The differences already we have discussed. In the long thoracic nerve, the entire scapula is displaced medially and upwards. In the case of a trapezius weakness, the superior angle deviates laterally, whereas in rhomboids it is the inferior angle that is displaced laterally. Hope this is clear to you. This explains the differences little more better. So this is the trapezius muscles. So when there is a weakness, naturally what happens, the upper pole goes laterally. When the rhomboids is affected, the lower pole moves laterally. Both are lateral winging, but a subtle difference is there. When the serratus anterior is involved, the scapula moves medially and a little upwards. Hope it is clear to you. Remember the root value, the long thoracic nerve is C5, 6 and 7. And the most common cause is medial winging. Let us see what is the problem here. You can see the drawing midline. You can see that the scapula has moved laterally, the medial border is prominent. So this is a lateral winging. So lateral winging can be either due to trapezius weakness or rhomboids weakness. Rhomboids weakness is very subtle. And second, you look at the contour of the shoulder, you can see the contour is lost. The normal contour is by the trapezius. So you can see this is especially clear from the frontal view. So this is an example, trapezius producing lateral winging. Hope you have understood the two types of winging: medial winging by the serratus anterior weakness and lateral winging due to trapezius or rhomboids. And we have discussed the differences, how to differentiate between these two, and the major causes of winging of scapula. If you like this, please subscribe to the channel. Thank you.